Uh, Hello, everyone. Thank you for joining and coming today. My name is Chao Liu. I'm currently in the master program of biomedical and health informatics at UNC Chapel Hill, and this is my internship presentation. This internship was with the Division of Healthcare Engineering in Radiation Oncology Department of UNC School of Medicine, where I participate in 3 well-being deep dive and other program and projects at the UNC Medical Center and UNC Rex Healthcare. So in June 4th, 2021, a survey from Washington Post named Kaiser Family Foundation Survey involved with more than 1,300 frontline healthcare workers in the United States during the COVID-19 pandemic have revealed that medical burnout had reached epidemic portion and overwhelmed 55% of frontline healthcare workers reported burnout. And between December 9, 2021 and January 24 of 2022, nearly 2,500 US physicians responded to a survey from Mayo Clinic, Stanford University of Medicine, and also the University of Colorado School of Medicine. And overall, 62.8% of physicians had at least one manifesting of burnout in 2021. And the growing trend were consistent across all specialists. Factors of burnout may include early issue of insufficient personal protective equipment, increased workload, a risk of infection of COVID, and lack of vaccinations. While treatment for COVID-19 has improved, but physicians are still grappling with new challenges. So, what is burnout? The International Classification Disease ICD-11 describes burnout as syndrome result from poorly managed chronic workplace stress. It's categorized by dimensions. It's the feeling of energy depletion or exhaustions, increased mental distance from one job, feeling negativism or cynicism related to one's job, and reduced professional efficiencies. Another measure worth mentioning is resilience. It's a measure of a person's ability to cope with stress. People with higher resilience may have better mechanism of coping with stress, thereby reducing the risk of burnout. So speaking about burnout, what specifically is physician burnout? So according to American Medical Association, physician burnout is a long-term stress reaction that can include emotion exhaustions, which is high in people at risk of burnout, dispersonalizations, which is the lack of empathy or negative attitudes towards patients, which is also high in people at risk of burnout, and the feeling of decreased personal achievement, which is low in people risk of burnout. So what are experts saying about physician burnout? Physician burnout is an epidemic in the US healthcare system, with 38% of physicians reporting signs of burnout, such as emotional exhaustion and depersonalization at least once per week. And this is the research outcome of clinical change in burnout certification with work-life integration in physicians and the general US working population between 2011 and 2020. While many factors contribute burnout, the burnout epidemic is often associated with system inefficiencies, administration burden, and increase of regulation and technology requirement. And by the quotes of the Vice President of Professional Certification of the American Medical Association, Christine Sinsky, we know that physician burnout is not only on an individual level, but at a whole system level. And here is the team of the well-being deep dive. Next, let's talk about what is system analysis. So according to the science direct topic, we know that system analysis is a process of studying a procedure to identify its goal and purpose to create a system and procedure that would efficiently achieve them. And why do we need system analysis in healthcare? It's because healthcare system is complex. So the healthcare system is a diversity task that involved in the delivery of patient care and the dependency of healthcare provider on one another. There is diversity of patient, clinician, and other staff. There is a huge relationship between patients, between career, healthcare provider, support staff, administration, patient family, or community member. And there is a variation of clinical layout and clinical environment. And there's a variation of different specializations, the implementation of new technology, and the diversity of care pathway and organization involved. And in order to improve physician well-being, we need to determine the cause of stress that can lead to burnout. Here, team that typically multidisciplinary with people performing multi-role and with high level of coordination and reliability being necessary. So we need to recognize all the breakdown at different level of in the healthcare system, and breakdown can rise at any level of the system. We need to take a look into, we need to take a system analysis approach to investigate them. And in 2017, the National Academy of Medicine had launched the Action Collaborative Clinician Wellbeing and Resilience and created a framework for system approach to understand clinician burnout and professional well-being. And the diagram that you can see here on the right side, it's a screenshot from a special publication from the NOM framework, the National Plan for Healthcare Worker Wellbeing, and it showed the system model of physician burnout, which is also what our methodology was based on. The 21 factors listed by the NOM can originate from different level of work system, and they're categorized into job demand and job resource that you can see I have listed out on the right side of the table. Next, let's move on looking into the timeline for the well-being report. The highlighted part here is the project that I was involved in. You can see the first project was back in 2018, and it's an ongoing effort of the whole team. There are more projects going on currently, and there are more quality improvement work and implementation work in the process. So next, let's move on to what our methodology. The well-being deep dive is user sequential mixed method design that was theory-based, participatory, and data-driven. And the overall goal of the well-being project is to improve the work life of a healthcare provider and staff. And so by kicking off the project, we use a survey to quantitatively assess burnout and assess participant participations, perceptions of severe level of each workplace stressor, as well as their priority and their participants' comments. Next, we present the survey result that we have analyzed to the participant in a focus group to get the contextual information from the mixed position group discussion. We then conduct a contextual inquiry to gain detailed insights into breakdown. It allows us to observe breakdown that participants may not be aware of as they find workaround and learn to live with them already. It also shows participants to provide candid opinions that they may not be able to express freely when they are in front of other colleagues. After that, we move we model all the qualitative data from the previous step, and then we ask the participant to validate the breakdown that we had identified and express their top 5 factors for the improvement. And finally, we make recommendations for improvement to the hospital leadership. The process was sequential. Information gathered from each page was used to the next step. And during the entire process, including the recommendation, was based on the point of view of the participants. Here we can see, here is the diagram of the methodology, participant timeline commitment, and the timeline. So as the methodology was a participant driven, it required a time commitment for every participant. And this figure will show the expected timeline for the project and the time commitment of expected participant at each stage of the approach. So the survey might take about 20 to 30 minutes to complete, and the department leadership have provided protected time so participants can complete the survey during their working hour. And the survey typically remain available for 2 or more weeks, depend on different departments. Next, moving on to the focus group, they were about 45 minutes long, and they are also conducted during their working hours. So people that work on different roles can participate. Due to like the different characteristic of the emergency department, the focus group of the UNC Rex ED, it's a little bit shorter. Next, into the contextual inquiry part, this involved one or two of our members shadowing a participant about 3 to 8 hours, and then conduct a 50 to 30 minutes private semi-structured interview. And this does not interface with participants being able to get on their daily task. So no protected time is needed. Any data that is captured during the stage with the consent of the participant and is anonymous. Next is the validation prioritization part. It's about half an hour long. After that, we make recommendation. And at the recommendation stage, this does not require more time from the participant anymore. So altogether, the project normally runs around 9 weeks, but depends on every department as well. And with the overall commitment for individual participant, it's 2 hours plus the time they were being shadowed in contextual inquiry. Here we can look into a little more detail about with each project that I was involved. The UNC Medical Center Department of Radiation Oncology only enroll physicists, and all department members were invited to the deep dive of for the UNC Rex ED and for UNC Rex Radiation Oncology. Here are the timeline of the 3 projects. We can the UNC Rex UNC Radon physicist start in the middle of May and ended in the middle of August. The UNC Rex ED kick off at the beginning of July, and the Rex Radon started in mid-July. And both are still ongoing, so we can see there is an overlap between projects. Now, let's take a more closely look at each phase of the well-being deep dive, and starting with the survey. So with the goal of the survey, it's to identify the top-rated workplace stressor that can cause burnouts and to prioritize the improvement. As I have mentioned earlier, the survey question was designed based on the NAM, which is the National Academy of Medicine theoretical model of burnout. Starting with the large concentric circle you can see on the left, we can see that stressor can oriented at any level of the workplace or working system. We have 21 questions designed based on the NAM framework, and we asked the participants to rate those factors for severity and priority. And beside participations, beside prioritization, we include like free text response into the survey to collect any additional information and more detailed factors. We collected information about individual factors that include two item corner divisions resilience scores. In order to understand individual factor, we have also collected demographic data, and these characteristics of individual can affect the level of impact that stressor may experience on the individual. And for defining burnout, we use a 2-item abbreviated Marsden burnout inventory to measure burnout. And through the free loop, we can see the burnout affect not only individual, but those around them, which can affect the whole system. The deployment of the survey, we deploy the survey as Qualtrics link, and no identifier was collected in the survey. Every participant that can only complete the survey once. So for all 3 surveys, the department leadership provided protected time for the participant to complete the survey. And what my role in this, I formatted the survey for different departments, generate the survey link, and how formatting the email for sending out the reminder. Analyze the results. I also build a Python code and format them into a Jupyter notebook that can be reused for any well-being deep dive in the future. And here we can see there are a total of 3 surveys, 1 per project that it's generated. And this slide shows the quantitative results for the survey. The most important things to note here is there are high burnout across all projects. And this slide shows the priority rank for each survey. And you can see here among 3 surveys, inadequate staffing, excessive workload, and time pressures are all ranked top 5 in across different departments and different hospital setting. And between the UNC Radon physicist and the UNC Rex Radon, a manageable work schedule are both ranked top 5 in these 2 departments. Next, they move on to the focus group phase. The goal of focus group was gather contextual detail about the most severe and the highest priority stressor that we have identified in the survey. So during the focus group, we present the qualitative survey result to a mixed row of participants in a protected time, along with comment from the survey to the participants. We use an open-ended question to promote discussion and then collect more specific contextual detail. The reason for this is through survey, we have collected the viewpoint of an individual already. So for focus group, we want to collect the group perspective that allow participants in each row to interact with the individual perspective of other row. So we offer a mix of focus group, which is in-person, virtual, and hybrid to maximize the engagement. At the end of the focus group session, we will give participants a priority pool to see if their top ranked priority have changed after focus group. So I have participated in 6 focus group, including note-taking, and creating deploy, analyzing the prioritization pool. And here we have 9 focus group. We have hold in total of 9 focus group. So here we can see like the shift of the results before and after focus group. We can see that work-life integration and extrinsic motivation and reward have shifted higher after the focus group. And this is the result of the UNC Radon physicist project. And here we can see the result of the UNC Rex emergency department. We can see that before the focus group, physical work environment wasn't included, but after focus group, it's ranked as top 5 of the priority rank. Next, this is the UNC Rex Radon. We can see that unmanageable work schedule have shifted higher as in their priority rank. And work-life integration have been added to the priority rank after the focus group. Moving on, we went into the contextual inquiry phase. And here the goal was to unobservably observe the behavior and capture both negative and positive real-time events rather than just relying on the participant recollection and their belief. So in contextual inquiry or shadowing sections, participants were observed inside their work setting for approximately 3 to 8 hours, allowing them to describe their task when appropriately and asking questions when it's not interrupted their workflow. For example, when in the radiation oncology project, participants may be shadowed in their personal office, in CT simulation room, in UNC Medical Center, might also be shadowed in their cyber room or radiation therapy treatment room, etc. And we capture both positive and negative real-time events by note-taking. Before the end of every shadowing, we have held a semi-structured interview to review what was taken into our notes and to gain a little bit more insight. And the data review breakdown were not always apparent to the participants. So each contextual inquiry will follow up by a interpretation sessions with the research team to report and discuss the key finding from shadowing the participant. The contextual inquiry involved being available and flexible in the same time. So changing plan at the last minute can happen because maybe a physicist need to change their schedule from late night pod to early pod, or a registered nurse from emergency department need to become a sitter that day because a psych patient had come in. So Any of these reasons can result in canceling the shadowing sections. So we shadow participants in morning, in afternoon, on weekends, and even on their night shift. Still, there are cases where shadowing isn't possible. For example, some executive team are still working remotely because of the pandemic. So trying to shadow them is impractical. And when shadowing, sometimes sensitive situation would happen that we need to be avoid. So such as a private consultation with the patient family, or that would be a rapid response call that we would need to follow, observe, but we need to keep a slight distance to allow participants to do their job. So as observer, we are required sensitively and discretions to keep our distance in some circumstances. And in the contextual inquiry part, I conducted over 10 contextual inquiries, participants in all interpretation sessions. And in total of 3 projects, there were 36 contextual inquiry being performed. Here shows a little bit more detail for the contextual inquiry, the participants and their positions that we have shadowed. Next, we are moving on to the modeling phase. So once we have collected and identified, once we have collected all the data, the qualitative data from the survey, from the focus group, and from contextual inquiry, we will model the breakdown. So before the actual modeling, we would gather all the qualitative data from survey, focus group, and from contextual inquiry and make them into affinity card. And the modeling process is an iterative process in which model is generated based on all text data. We will meet together as a team to categorize all the breakdown and stick the affinity card on the wall and develop the affinity diagram to capture the broad range of breakdown in the work system in PowerPoint. I was involved in all aspects of this work. I built a reusable tool for data card to generation and help preparing all the data card, building the model, facilitating in sessions, and analyzing the results. And for 3 deep dive projects, there were a total of 3 affinity diagrams being created. And this is what a affinity diagram look like. I have kind of blur out the text data, but you can see, for example, and this is for UNC Red physicist. For example, under inadequate technology implementation, there can be other factor can break it down into machine issue, machine repair issue, or issue related to their system like Electa or Mosaic. After we have the affinity diagram, we move on to the validation and prioritization sessions. So we will model all, here we would send the result back to the participant for validation and for them to rate which breakdown were the highest priorities for them. So as mentioned, once we have the affinity diagram, we will hold a validation and prioritizations, which we offer in multi-mode wherein the participant validates the breakdown. The participant will be asked to validate the model by marking them what they think are not related to. And they will also instructed to write correlative and elaboratory comments as needed, and to prioritize their top 5 stressors from the item in the affinity diagram. So disagreement of the breakdown in the affinity diagram is expresses as number of the participants disagreements with a specific breakdown to the total number of participants in the validation exercise and the validating the breakdown. And what do I do during this stage? I was involved in preparing data. I was involved in 2 validation sessions and analyze 3 of the 5 sets of validation prioritization results. So during these 3 deep dive projects, there were 7 validation and prioritization sessions being held. And this is what a validated affinity model will look like. This is also an example of the UNC Red physicist, and we can see that In this project, we have reached a 76.8 degree of agreement, 8% of agreement. Next, we look into the prioritization of breakdown. These are the top priority that we have identified by participants and have consolidated them. And for an example, this slide shows the top priority across 3 projects. And by comparing the 3 projects, we can see that there are some common things that can be identified, such as electronic modifications, inadequate staffing appears in all 3 projects as well. An excessive workload appeared in the both red on deep dive between UNC Medical Center and UNC Rex. And finally, we need to identify which top priority breakdown from the validation prioritizations were best to put forward to the hospital leadership team as good target for improvement. So by doing this, we use a participant-driven impact and after analysis. So after the top five priority were consolidated into multiple priorities, we will share the result back to the participant, and the participant were asked to organize these priority against 2 variables. One is the level of impact, which is how much value or impact will the outcome have to the department, and level of effort, which is how many time, money, and resource and capacity that will be needed to achieve this desired outcome. And the pool was analyzed, and the response was plotted into the impact and effort metric to identify priority with high impact and low effort, and high impact for high effort, and top recommendation were determined based on rating provided by the participants. So there is a total of 4 prioritization pool being deployed. What I do here is I consolidate top priorities from 1 out of 4 validation and prioritization sessions. And I compare all 4 prioritization pool and email them and help formatting the generating the email link to the participants. So let's look into the example of the UNC random physicist. We can see this is an example of the impact and effort metric. So any of the high priority, any priority breakdown will fall into high impact, low effort area that is shown in green, or high impact, high effort area that is shown in yellow, and low impact, low effort, which is shown in orange, low impact, high effort, which is shown in red, were put forward to leadership team as recommendation. And here, as my role, I help to build the impact and effort metric and draft recommendation. This is an example of how the contextual description of each of those sample recommendation. So let's recap on the theory-based, participatory, and data-driven sequential mixed method design that we use in these 3 deep dive. So first, we start with the theoretical work system factor from the NOUN framework. And then through survey, we gather individual opinion on the severity and priorities for those work system factors. And then through focus group, we gather a mixed row group level data and allow participants to interact with a few viewpoints other than their own. Next, we conduct shadowing. We gain a deeper contextual understanding of a specific breakdown using observation and interview. And then participants were then asked to validate the breakdown that we have identified on the affinity diagram, and they told us their top 5 priority breakdown. And finally, specific improvement goals were identified through a participant-driven impact effort analysis and recommendation to the hospital leadership team. The reports were written in Word and formatted in Adobe Design and were made available to the participant and the leadership team as a URL link to distribute through email. And for creating the UNC Radon physicist reports, I used the trauma surgery report created by Viola as template. And these report is written mostly designed and written by Liz and I. And the UNC Rex ED and the UNC Rex Radon report are still in the ongoing process. Beside the well-being deep dive, I also participate in multiple projects with the DHE team, publication on magazine article and journal article. And these are the ongoing project that I am still working on with the DHE team. The first of utilizing machine learning approach to prioritizing factor contributing to clinician burnout. This is the work that we utilize machine learning approaches like mutual information, chi-square, recursive feature elimination model to perform feature selection to prioritize factors that can contribute to clinician burnout. And we use the same data set collected from the well-being deep dive and classify the data with burnout and non-burnout. And as a continuation of this project, for my current project for schoolwork, I also analyzed with text mining and natural language processing approaches to understand the text data inside through the well-being survey. This two study is, the purpose of these two study is to discover and understand the barrier of electronic patient-reported outcome assessment completion among lung cancer patients to improve patient reporting and syndrome data capture after the treatment ultimately. And patients that have undergone surgery have high symptom burden, particularly during the early post-operative phase. The user-centered research have limited the assessing underlying reason for EPR completion, particularly during the time period immediate of post-surgery. So we aim to assess usability in the form of efficiency, effectiveness and certification, and understanding barrier to confirmations that can be translated to other EPRO assessments and patient populations. This is a magazine article written about a core pillar of industrial engineering is learning how to overcome the inefficiency workflow and system in the emergency department. Industrial engineers create efficiency where they aren't and hold a unique position within engineering disciplines and with their skills highly adapted to the field of work. In the case of healthcare, industrial engineering hold enormous opportunity to revolutionize and optimize the nation's healthcare infrastructure. By using data-driven engineering solutions, industrial engineers have potential to dramatically reduce patient waiting time and human error that lead to patient harm. And this is an article that I have written with another intern, Ben, who is also involved in the well-being project. So I have learned so much during this internship, include shadowing and interviewing healthcare professional and in focus group and definitely more. The internship is a lot of hard working, but it's very interesting and very rewarding. Before moving on into other later of my presentation, I want to acknowledge that the Wellbeing Deep Dive program is an effort between multiple members across the DHE team. Definitely, I would like to express my special thanks to everyone in the well-being team, including a supervisor, Dr. Muzia, who have gave me the golden opportunity to work on multiple and wonderful projects. And I would definitely like to thank Kartik, Lise, and Dr. Visor for their special guidance on and outside of the well-being deep dive. And thank to all members of the DHE team having me on the team and across multiple projects. And beside having my internship with the DHE, I also have complete other internship. The first one is with the Perinatal Research Service Center During this internship, I have conducted 4 literature review across different topics based on research interest, and I have a really great opportunity to learn how to create like poster, how to make infographic more easy to read and simply to understand. And during this internship, they're learning a little bit more about data visualizations. I have performed the data visualization with D3.JavaScript on CDC public reproductively health data set. And during the time for this internship, week by week, we can always heard other students' presentation on different perinatal related research topics. So I definitely have learned a lot and have a great time during this internship as well. And the other is Novant, the Novant Health internship with the business intelligence operation teams. So I have a data analysis project on topic, does having an PCP impact on patient outcome, and conduct different literature review across topic like AI and machine learning in healthcare, and an overview of healthcare system in different countries. And during this internship, I have learned to communicate, how to build relationship with people I've worked with, and not only learning from a research environment, I also have learned a lot of new things for industrial professionals. Definitely ask questions everywhere in every process and never be afraid to ask. So thank you so much for listening to my presentations. And I wonder if there's any questions that I can help with answer.